Awesome. Well, thank you. Thank you. And Jackie, amazing presentation. Thank you for sharing both the personal and professional content. That was amazing. I'm excited to be here and speak with you all. A little bit about myself. I'm originally from Pittsburgh, Pennsylvania. I was a surge tech in training when I found the field of donation. I started in 1994, where I did the actual recoveries of tissue and eyes. So tissue is long bones from the arms and legs, skin, tendons that are used to treat burn victims, sports medicine, dental procedures, and I assisted the surgeons on the recovery of organs. As I was furthering my career, I was given the opportunity to actually talk to families, both in person and over the phone, about donation. And in the 90s, we had a program called Like Requester. And the Like Requester program, as it sounds, was if there was a Black family, they would call one of the Black donation coordinators to speak with them. If it was a Hispanic family, the same. And when I started, I told them, I don't think this will work. However, I'm willing to give it a go, but it cannot appear and look like you're calling in the Black team and make it obvious. And I remember early on speaking to an older Black woman about donation. And she stopped me and said, I'm sure you're very qualified. However, I want to speak to the white man in the white coat. And it kind of struck me odd. And that's really what started my journey into understanding why people say yes and no. And what I learned in that, after that experience, is there's a demographic within the Black community that believes or believed that only older white men, specifically, not even white women, but older white men, were given the education and the tools needed to treat them. In 2002, I moved to the South. There was a similar program here, and I said, absolutely not. Moreover, do I not believe it's going to work? I am a Yankee, and that is going to supersede anything over having a relationship in the South. The other thing I learned as I came to the South from Pittsburgh is the Northeast is broken into townships, or each city is broken into areas. So you have Little Italy, you have Chinatown, you have Polish Hill and the Russian district. And if I asked a white person in Pittsburgh growing up, what are you? They knew. I'm French, I'm German, I'm Hungarian, I'm Polish. When I moved to the South and I asked a white person, what are you? And they say, I'm just white. I'm American white. I'm just normal white. And I learned very quickly that the South was really Black, white, Hispanic, where the North was broken into regions because that's how they, as the people immigrated to America, that's how they set up familiarity. So this really started to excite me, and is what led me down this path of a lot of research. So excited to present today, and if there are any questions, please interrupt and we can dive in more. So I'm going to talk about 200 years of why there's a mistrust in minority populations. One of the slides that Jackie presented had this breakdown. Caucasians are 77% likely to say yes to donation, while the minorities combined, Black, Hispanic, and Asian, are around 55%. And when we talk about research specifically, that number drops below 10%. And we're going to talk about some of the whys as we go through the presentation. So Why is there a disparity in donation? It's not just donation, that's what I'm focused on, but it really starts at the level of healthcare. And there's a lot on this slide I'm going to touch on each of these. Most of us are aware of Tuskegee and Henrietta Lacks, but it goes so much deeper than that. In the 1800s, it was illegal for practitioners to use corpses, dead bodies, to do research. Medical College of Georgia is one of many medical institutions that did grave robbing. Not only did they do grave robbing, but they specifically dug up exhumed the bodies of Black people at a time where it was against the law, but they specifically chose Black people because Black people didn't care. It didn't matter. And this spurred a lot of debate. And while it was illegal for them to do this, there was never any justice for the families of the bodies that were exhumed. Marion Sims is heralded as the father of modern gynecology, and he performed horrific surgeries on Black women, thinking that they experienced less pain. And while anesthesia was available, he did these procedures without any anesthesia. Compared to their white counterparts that often benefited from these procedures, they were given anesthetics and pain medication. Won't talk a lot about Tuskegee, except I will say I personally was born in 1972, and that was the year that Tuskegee ended. So this is not something that happened in the 1800s or 1700s. This happened within my lifetime. And Tuskegee was a reason that my parents, my father and my uncles refused to go to the doctor, because they lived and understood what that was. And that mentality was really preached to me when I was very young. Don't go to doctors because they're not going to treat you. The First Nations nutrition experiment happened in Canada. And this is in the 40s and 50s, sponsored by what is now Health Canada. And what they did was, in the Indigenous population, purposefully gave them, the children specifically, illegal, outlawed flour and other foods to understand the impacts. And hundreds of these children died from malnourishment. Henrietta Lacks, if you're not familiar with, is still an ongoing present today debate and lawsuit where Henrietta Lacks' blood and genes were stolen without permission and are currently being used. And, you know, the argument on one side is the ends justify the means. And a lot of important and great breakthroughs have come through from this cell line. However, the family has never been compensated. There was never any authorization or consent provided. So in essence, they were stolen. The Cincinnati radiation experiments occurred in the 60s and 70s, and Black and Hispanics were primarily the targets, where they were bombarded with high doses of radiation to understand the impacts of radiation on the body. The New York psychiatric experimentations occurred in 1996. And what they did is looked at siblings of criminals, gave them, without the knowledge, there was consent, but it was not obtained appropriately, to try and understand if there was a correlation in siblings to be more apt to purport crimes. And they were given high doses of different medications and things like that. And more recently, and Jackie, you touched on this a little bit, race norming. And there's a test called EGFR that's used to normalize testing when a Black person is being tested specifically for kidney function. And I understand there's a class action lawsuit. I don't know where it is that's being filed or has been filed. But in 2024, in Winston-Salem, it made the papers, and I think it was nationwide, that hundreds or thousands of Black people were delayed or denied access to being put on the kidney waiting list because of this EGFR testing, knowing, and they've known this for at least a decade, that the test is not accurate. So this is a very quick rundown of a couple hundred years of history as to why the minority communities have a mistrust of the medical system. This mistrust of the medical system extends to donation because donation is the medical system. It is the healthcare system. There are some lingering biases. In 2016, Serena Williams had a harrowing experience after delivering her child via cesarean. And if it wasn't for her self-advocacy and her position, and I think that allowed her self-advocacy, she probably would not have survived following the childbirth. But there's a lot of research that suggests there's a lingering bias that continues today on pain management, maternal management. And if you look at the statistics here, there are 43.5 deaths per 100,000 live births in Black women, compared to only 12.7 per 100,000 live births in white women. And one of the studies that I read just blatantly stated it's the structural racism and implicit biases that are contributing factors to these numbers. The study went on to talk about, again, today, not hundreds of years ago, false beliefs in the medical community, that Black skin is thicker, that minorities have a higher threshold for pain. And I think this really is evident with the current opioid crisis in the country, that it's more affecting white America because white Americans are given an overprescription of pain medications, where it is withheld from Black Americans. So that's the lingering bias that still exists and is well researched and well documented. So here at Miracles in Sight, we actually performed a study where we partnered with an cornea fellow and the Center Coalition for Health, CHC. I can't remember what that stands for exactly, but they're a Durham-based organization, nonprofit, that really is aiming at looking at health disparities and focusing on the Black community. And in this, what we found in the Southeast, and I'll be very specific here, is that there are three main reasons that people say no to donation, Black and minorities say no. And one is the overwhelming mistrust of the medical community. And I think it's well-founded, I think it's well documented. And while things are better, it's not something that we can just get over. Number two are the religious beliefs. And again, Jackie, thank you for pointing out the pastors and the preachers not being prepared to have these conversations, even though the congregations look to them as advisors. Lack of conversation. One thing that I will mention as well is I am mixed. My mother's white, my father's black. And on my mother's side of the family, they talked about death openly. And it was not something that was talked about on my father's side of the family. And I think it's the lack of conversations about death, what happens after death, that need to become a little bit more normalized in minority populations. And I presented this to the National Association of Eye Banks, and I've asked that others take up the same study to see if these reasons that people are more likely, minorities are more likely to say no to donation are nationwide. Because at the end of the day, what we have to do is take this information, and if it's regional, we have to craft language that is specific to the region. If it's national, then I think it's a little easier in that we can craft language that is more nationally dispersed. But I think things that have to happen, we have to acknowledge the past. There's no way of healing. So as Heather and I were talking yesterday, I gave her an example. If you are in an argument, a serious argument, you can get past it when someone says, Heather, I'm sorry I offended you. What I said was wrong. It was taken out of context, but we have to address it. And that's how healing starts. That's how we can kind of overcome that. But what we're seeing in the country now is the whitewashing of history. In Texas and in Florida in the 2010s, so again, we're talking a decade ago or so, in Texas specifically, they approved the removal of the word slavery and intended to use indentured servitude. They have very different meanings and they are not the same. I don't think it actually went through because a lot of people, there was a big uproar over it, but this is what the educators, not the teachers, but the education board approved. Currently, we're looking at the removal of CRT because there's a misunderstanding of what critical race theory is. It's kind of like how woke has become politicized, and what woke has meant historically is now something completely different, and white fragility. All of this comes down to white fragility. There's a book that I intend to read, I have not yet read it yet, of the name White Fragility, that I hear is extremely eye-opening. Advocacy, we have to become advocates, and this is both personal and institutional. We cannot just accept what the medical professionals tell us. We have to seek second and third opinions. I actually had a friend who at 17 was tired of going to the doctor because she didn't receive any answers. And that's medicine. You know, it's a process. You look to eliminate the easiest things first until you get something more rare. But we have to become better advocates for ourselves. The institutions also have to become advocates for ourselves, for us, not ourselves. So Jackie, please continue. Thank you. I know you will become that advocate. When I was looking for a new primary care physician 2 years ago in Winston-Salem, I wanted a Black man. There was only one that I could find, and he was not accepted in my insurance network. So I did find a Black woman who spent 50 minutes with me on our first visit. My prior PCP in 10 years may have spent 50 minutes total with me. And in that visit, she looked at my numbers. She called me a week later and said, I'm going to send you to hematology. I don't know that there's anything wrong, but your numbers are not trending correctly. And I was diagnosed with bone marrow cancer. Had I stayed with my prior PCP, I don't know that it would have been seen. Thankfully, they caught it early. I take a daily chemo pill, so I'm good. No, I've never had a symptom or anything. But I don't know that would have been the case if I would have stayed with my other PCP and she was not my advocate. Because when I went to the hematologist said, I don't know why your PCP is sending you here, because my numbers were normal. They were just trending up. And she called me a week later and said, yeah, it was a good thing she sent you. So again, it comes back to the personal experiences that we have and the advocacy. My PCP was my advocate. We have to create and continue the research, create educational content specific to our populations. We have to include the church. We have to give the church the tools necessary to speak on all of these subjects in its repetition. I read once that you have to tell an adult something 7 times before they actually hear you. So by saying it one time and walking away like, oh, did our job, we're good, it's not enough. It has to be continual. So that is my presentation. I have a bunch of citations if you're interested in anything more. And I'm happy to take any questions or have a conversation.
Thank you. I am you're getting some claps and love, and it has started conversation on the chat. I am blown away, and I didn't know all of that. So and you and I talked before this. Thank you. Are there questions, thoughts? I was bombarding Mike yesterday with issues as an educator. I'll just tell you, I asked Mike, is it safe? Is it appropriate for me to be standing in front of these churches with Morissette and to say, we really, organ donation, acknowledging the mistrust, acknowledging the issues, but saying that the organ donation process is safe, it's important, and encouraging, because I had a little bit of an ethical issue. And Mike, you said yes, I can we really need to be encouraging organ donation.
We have to be advocates, because the largest population awaiting an organ is kidney, and it's Black people. Mm-hmm. And it's easier to find a match for kidneys, specifically within an ethnic population. So if we are not saying yes as a people, our people that need are less likely to receive. Mm-hmm. So to me, this is not, there's no ethical dilemma. It's acknowledging that there is disparities. It's acknowledging that there's mistrust. It's confronting the myths head on. And as I told you yesterday, some of the myths are based in pseudo faith, I'll say. And it's hard to argue faith. But the ones specifically where they say, if I have the heart in my driver's license, or if I'm signed up to be an organ donor, they won't save me.
Yep.
To me, it's a very easy argument, because one, and probably most importantly, if they do not save you, if they do not keep your organs functioning, your organs die, and then you can't be a donor. So it defeats the purpose of working to save you. But at the end of the day, if we are not donating, people die.
Mm-hmm. Mm-hmm. So there's questions and praise coming through the chat line. I think the thing that I'm seeing the most is appreciation for sharing the information that this was eye-opening, and it's important knowledge to have, and to thank you. There was a question, and I was thinking as well, would it be okay if we have a copy of your slides, if you can email it to me and then I can
Yes.
make them available? Great. And then I see Marisette has a question.
Yes, wow. What an amazing presentation this morning, first from Jackie and then from you, Mike. And the question I have, and something that you raised today, oftentimes we're talking with clinicians on how to engage with their Black patients or Latino patients, people of color. And a point that you made today that I don't think we often consider is, as a provider, and I'm a nurse, and so I was in the situation years ago where I was a Black nurse caring mostly for white patients. So, in that regard, getting their trust to have me be their nurse.
Mhm.
But as we think about the mistrust based on factual things that have happened, as providers, should we take a moment to acknowledge that we know, is that the right approach for clinicians that are caring for patients that don't look like them, to acknowledge that yes, there have been some wrong things that are done, but it is our goal today to provide you the very best care. I mean, how do we, because I think sometimes there's this elephant in the room and we're afraid to talk about it. And it's the thing that's holding us up from getting that person the care they need.
Mhm. That's a great question. And I think, well, I know it's going to be situational. Um, the reason that I was looking for a Black man to be my PCP is that at a higher level, there's going to be some unspoken understanding, the assumption that there'll be some unspoken understanding. I know women who only want women to be their OB-GYN because there's a comfortability there. So I think it's trying to understand what the hesitation is between you and the patient. And so I like to think kind of with analogies and examples. So if I'm a patient and you see I haven't been there in 10 years or 15 years, I haven't been seen at all. Why? And I think it's starting there. But if it leads you to believe that there's a mistrust, then I think it's fair to then say, I know that there have been, some horrendous treatment of, in your case, our people, if it's a Black person, throughout the years. I'm here to help you overcome that. Is that a issue for you? But I really do think it's very situational. But I don't think it's something that we should shy away from if we feel that is the situation.
Yeah, I appreciate that. I know there's a lot of work being done now on how to have end of life care conversations, and how to help our young physicians, and I think a lot of it goes back to what Charlotte said, how do you engage with people? You have to see where they are. What is their
Right.
story? And take a moment. You said your doctor on the very first visit spent 50 minutes. So she took time to get to know you. And it's hard to build trust with people if you don't take the time to get to know where they've been, what's on their mind, what it is that needs to happen. So thank you again. This has been very, very good for us, and information that we can share with others as well. I bet you that you're going to be getting lots of people blowing up your email wanting you to do this talk. So I'm going to be one of them.
I love doing it. So,
Thank you.
the schedules permit, I'll be there.
Actually, that's a good because I saw Charlotte made a comment, and Marset did, if you wouldn't mind putting your email in the chat line. Basically, this is what happened when I met you at the License to Give Trust Fund Commission, and I was like, copy and paste that. Are there other questions? Again, that a lot going on in the chat line with appreciation and wondering, especially those of us who are educators, how to infuse this into our work and to, as we say, acknowledge, as you said, acknowledge and really address things and then educate. Oh, there we go. There's Mike's email. Any other kind of questions, issues? We saw the praise. All right.
And I will say, I put in the chat, if I don't respond immediately within a couple of days, please email me back. I get so much junk email. I have a bad habit of just selecting big swaths and deleting them. So please email me back if I don't get back to you within a day or two.